All right, let's talk about something we all deal with every single day in the OR, those tricky fluid and electrolyte challenges. This whole explainer is designed to cut right through the noise and give you the high-yield, actionable stuff you can actually use. So let's just jump right in with a scenario that I'm sure sounds familiar. You get the pre-op labs for your next elective case, and boom, sodium is 155. What's your call? Do you proceed or do you postpone? This is exactly the kind of clinical dilemma we're going to dig into today. So keep that number, 155, in your head.
First up, sodium. And you might be asking, why start here? Well, it's because when sodium is out of whack, it triggers these massive osmotic shifts that can literally make the brain swell up or shrink. If you get this wrong, the neurological consequences can be absolutely devastating.
At its core, it's all about a simple osmotic gradient, right? With hyponatremia, you've got low sodium outside the cells, so water just rushes in, causing them to swell. Flip that for hypernatremia. High sodium on the outside literally sucks the water out, dehydrating the cells. Either state creates a really high-risk environment for anesthesia.
Okay, this is the number that should have alarm bells ringing in your head. A sodium below 120, that is not just a lab value. It is a full-blown neurological emergency. That cellular swelling we were just talking about, now it's become severe cerebral edema. And that puts your patient on a direct path to seizures, coma, and maybe even permanent brain injury.
But here's the kicker, this dangerous paradox. Our first instinct is to fix that severe hyponatremia and fix it fast. But if you correct it too quickly, you can trigger something called central pontine myelinolysis, and that's an irreversible destruction of the pons that can leave a patient quadriplegic. It's a classic trap where the cure, if you mismanage it, is so much worse than the disease.
And this brings us right back to that first question I asked. The evidence-based guideline is crystal clear. For an elective surgery, a plasma sodium over 150 is a hard stop. It means there's a significant free water deficit that absolutely has to be corrected before you subject that patient to the stresses of anesthesia and surgery.
Okay, so we've moved from the neurological minefield of sodium, and now we're turning to the cardiac one, potassium. If sodium imbalances threaten the brain, well, potassium imbalances are a direct threat to the heart's electrical stability. We're talking life-threatening arrhythmias. A potassium level over 6? That's an absolute red flag. This level of hyperkalemia destabilizes the cardiac membrane, which can lead to arrhythmias and, even cardiac arrest. This is a value that demands immediate, aggressive action. No waiting around. So in the OR, our plan for hyperkalemia is built on one simple principle. Do not make the potassium any higher. This is non-negotiable. It means succinylcholine is completely off the table. So are potassium-containing fluids like lactated ringers. Your entire anesthetic has to be focused on stabilizing that cardiac membrane and actively driving potassium down. Now, on the flip side, with low potassium, we're just as careful. Giving IV potassium isn't about chasing a lab value. It's reserved for severe, symptomatic patients. The ones with clear ECG changes or profound muscle weakness. And when you do give it, you are watching that cardiac monitor like a hawk. Next up, let's talk about calcium and magnesium. Think of these two as the gatekeepers for neuromuscular function and cardiac stability. If they're out of balance, it directly impacts our anesthetic, from how potent our muscle relaxants are to the patient's overall cardiovascular tone. High magnesium creates this really predictable and dangerous cascade of depression. As the levels creep up, you see a clear progression. First, hypotension and bradycardia. Then you lose the deep tendon reflexes. Next comes respiratory paralysis, and finally, cardiac arrest. Each stage is a warning sign for what's coming next.
The key takeaway for us, intraoperatively, is the huge risk of acute hypocalcemia during massive transfusions. The citrate they use in blood products to prevent clotting, well, it binds up ionized calcium. So in a major hemorrhage, as you're pouring in unit after unit of blood, you have to be vigilant. You have to proactively monitor and replace that calcium to prevent serious myocardial depression and coagulopathy.
And hey, let's not forget about phosphate. It's less common, sure, but critically low levels can cause this profound muscle weakness that affects everything, including the diaphragm. This can show up as difficulty weaning from the ventilator, so it's a really important thing to keep in mind for post-op respiratory failure.
Okay, so we've gone through the key ions. Now let's try to pull all this together into some rapid-fire actionable principles we can apply every single day in our anesthetic management.
Here is a fundamental rule you should always remember. When faced with a choice, the body will always prioritize volume over salt concentration. It will save volume at all costs. That's why a hypovolemic patient will hang on to water, even if it means driving their sodium down into the danger zone.
When you're replacing blood loss with crystalloids, the classic starting point is the 3-to-1 rule. And why is that? Well, because for every 3 liters of crystalloid you push in, only about 1 liter actually stays in the vascular space. The rest leaks out pretty fast, so you've got to over-replace to maintain that intravascular volume.
Now, the trigger for a blood transfusion is never just a number. It's always an individualized clinical decision. But a hemoglobin below 7 is that widely accepted threshold where the risks of anemia often start to outweigh the risks of transfusion. That's when we really start to strongly consider it.
And finally, in a massive hemorrhage situation, our whole strategy shifts. We move to what's called damage control resuscitation. The goal here is to mimic whole blood by using a balanced ratio: 1 unit of packed red cells, 1 unit of fresh frozen plasma, and 1 unit of platelets. This approach tackles oxygen carrying capacity, coagulation factors, and platelet function all at the same time.
So let's end on this challenge. The next time you find yourself in a massive hemorrhage, how are these principles going to change your first move? What's your go-to fluid? What's your sequence? And what's your rationale behind it? Seriously, running that mental simulation right now is what prepares you for when it really counts.